Welcome to School Life Unpacked, the podcast for anyone navigating the complexities of their child's education. Join me, Natasha Curtis-Ego, and a lineup of insightful guests as we explore the challenges, joys, and surprises of school life, offering support and tips to help us feel more confident and connected. Today, I am very excited to be joined with a wonderful guest who, if you could take a moment to introduce yourself, that would be amazing.
Hi, my name is Dr. Taz Syed. I'm a local GP and I'm a named GP for safeguarding. And I've held roles locally and nationally as co-chair of the National Network of Named GPs, and I'm a GP partner as well.
Today we are going to discuss everything GP related when it comes to young people entering school, primary age, possibly slightly before early younger years, and how GPs support schools and parents as they transition into this new realm. Could you tell us what a GP does and your role when it comes to young kids, or young people, I should say?
So, in general practice, GPs are an interesting service. They're the only service that never discharges anyone. When people register with us and they're in our catchment area, if they stay in our catchment area, they could stay with us for their whole life and for their children's lives and for their grandchildren's lives. So we have many GPs who have worked locally for 30, 40, 50 years as partners in their practice, and they're on to the third or fourth generation of people they're looking after, of families they're looking after. So I can't underline the importance of them being lifelong service and watching the consequences of each decision that's made, whether it's therapeutic or whether it's interventional, conversations they have with people and their children to help them. So GPs are an interesting role. Of course, the other side of this is that general practice has evolved. So nowadays, when we go to our GP, it's very unlikely we'll actually see a doctor or a GP. For instance, in Pall Mall surgery in Lee, at the last head count of professionals we have 17 different professionals, ranging from paramedics to ECPs to pharmacy technicians to social prescribers to health coaches to children's practitioners. So there can be a really wide range, and those are just examples of the colleagues that are on the local practices list of professionals to see.
When you first have your child, in theory, if you choose to, you can have your child vaccinated. So that would be our first introduction to a GP practice. So that would be somebody within your catchment areas. It sounds like school, doesn't it? You have to be in the right catchment for the right GP surgery. With that, what would you then, that would be your first introduction to the children, I suppose, to the child who you may potentially grow with, if or not you, because it would be a nurse who you would see, right, to get your first vaccination?
So this is complicated again.
Oh, is it?
So the roles evolved. And again, before, your first introduction would be antenatal care.
Yeah.
And you'd see the GP and get antenatal care off your general practice, one of the team in practice, usually the GP.
Yeah.
And nowadays, antenatal care has been moved away from general practice, that actually you go into the midwifery service. And probably with a woman who's just had a child, our first contact would be the postnatal check. So it'd be the 6 to 8 week check before the first set of vaccinations for the child. And at that postnatal check, we'd see you in person, we'd see your baby in person, and we'd examine you, have a conversation with you, see what you were worried about, what your concerns were, do the basic checks for things that are common in both yourself and the baby. And we'd also gently encourage you to have vaccinations to improve prognosis and survival for your child. The other big thing that is a massive thing that we look for now is postnatal depression and anxiety and mental health. And we have a good old conversation about that to make sure you feel well supported and you feel included and your self-esteem is in the best place it can be to help you succeed.
And then, so after we've had that initial thing, we then progress to, let's say, nursery. Do you encourage people to bring their children in again just before nursery for anything? Or is that just not, you just go to nursery and then the next, I'm trying to think vaccination wise, because I chose to have my children vaccinated. I'm thinking of all the key points where we saw our nurse, or we were in our surgery, I should say.
So this is a really important point you're making. And actually, and I'm going to bring it back again, Natasha, if that's okay.
Of course.
After the 6 week check, you'll be seeing the health visitor, and I'll talk a little bit about health visitors. Just a quick definition of a health visitor. A health visitor is a really senior nurse. They've got a degree called a SCUFN, and they look after families and children where any member of the family is aged 0 to 5. Okay, so one of the great things about our area, and we're ahead of most other parts of the country with it, is that we all write in the same record, in the same TPP System 1 record. So I can see everything the health visitor's written, they can see everything I've written and any of my team have written. And that's where there's actually one true record for you and your family, for each person. So after you see me, you'll be seeing the health visitor, or maybe just before, you'll be seeing the health visitor. Forgive my inaccuracy there if I'm slightly wrong. But also then there'd be the 8-week jabs, there'd be the 12-week jabs, and there'd be the 16-week jabs if you agree to vaccination for your child. Now, those vaccinations, and I talk about survival and I talk about evidence and probability an awful lot, they're administered by really senior colleagues of mine. So often these nurses at the practice, they know an awful lot, they say an awful lot, they give a lot of advice. And then you see on the NHS app, often we write very little because we don't have enough time to write everything we've talked about and discussed. But these nurses, and again, I talk about Leigh-on-Sea and my practice 300 yards down the road, 400 yards down the road from here. But those nurses have often been at my practice longer than I have, and I've been there 20 years odd. So really senior colleagues, you're being looked after, and you can have any conversation with, whether it's about breast screening, whether it's about cervical screening, whether it's about mental health, and they can pick it up and they can come to the senior GP who's on that day and ask for help and ask for support and ask what to do next to help you.
Once you've had all those checks, so your health visitor looks after you until you are 5 years old?
Until your youngest child is 5 years old, they support you and your family.
Okay, and then so as you enter into school, what is the role of the GP with schools? And so you move over to the school nurse, don't you? Or I feel like I had a letter saying, oh, by the way, your child is no longer being looked after, health visitor, they are now under the school nurse.
Absolutely, and again, Natasha, I'm going to bring you back because obviously I'm quite an old, haggard GP. So after the 16-week jabs, then there's the 12 to 15 month jabs, the MMR jabs, and then there's the preschool boosters, age 3 to 5. So that's your journey in my practice, and then your child starts going to school, and as soon as your child is 5, the care of that child and their family transfers from the health visitor to the school nursing service. Now, in Southend, our local health visiting and school nursing service is one continuous service that's with our local council called a 0 to 19 service. It's pretty seamless and pretty good. Their big boss of the health visitors and school nurse are the same person, so they can see the whole picture. And I must say that senior person, who's I do believe is retiring this year, is someone who trained me, has worked in all parts of the system, has worked in safeguarding as a senior colleague as well. It's very helpful to have someone who has that level of that scope of knowledge when trying to support our young people and their families succeed at life. One of the things, Natasha, I always talk about is Maslow's hierarchy of needs. Now, Maslow is a very old system. It was there from after the war. So we're talking 70, 80 years old, and the evidence for it still stands up. And it's basically a triangle and what we need in life to succeed. And there's that basic food, shelter, warmth. Then there's emotional warmth and safety. At the top of the triangle is something called self-actualization, which is a very posh word, I think, just to justify our existence, to be honest. But what self-actualization means is every child and young person, every mother, every father hitting their potential, being the best version of themselves. And what we're trying to do is make sure that everyone has the best chance. Now, we have only a finite amount of resource, but what we try and do is divide it to make the maximum good for the maximum number of people, which again is a theological argument, and it's called the utilitarian argument. But we try and do that with the cloth that we're given and cut it as best we can to win families and support the majority of them. And the reason why that's important is because in Southend we've chosen to have this 0 to 19 service to encompass everything in the same place and keep it close to our local authority. I'll interchange words local authority and council, but they're the same thing. And that's where the school nurses, 5 to 18, they take over and they start looking at how we can support the basic things in Maslow. Are we brushing our teeth? Have we got the right tools are we ready at preschool and reception? Are we engaged? Have the teachers, have the school got somewhere to go to ask health for help? And they're a great bridge between general practice and the school.
So if you have concerns, so if the school nurse sees something perhaps that they feel they're uncomfortable with, as in they feel a child isn't quite ready for school, who would they go to? Would they go to the school and then the school can contact the GP, or would they go to the parent and the parent contacts the GP with the concern?
So there's several mechanisms for this. The first thing, again, the school nurses are really senior clinicians. They've got this scuffing qualification, they're senior nurses, they're really experienced guys. So the first thing they would do is look at the notes, look at System 1 and see what the GP's written in recent months, even years. See what the health visitor's written in recent months and years. And we're not just talking about, and this is where it's really hard to quantify the amount of work that goes into this, because nothing's written down. But you can't look at any person and help them in isolation. You need to see their life journey.
Yeah.
So to look at their life journey, you do need to look at their siblings. You do need to look at their parents. You need to look at other adults in the house. You might even need to look at extended people in their family. Now, of course, nowadays with EGDPR, and there's something called the Caldecott Principles of Information Sharing, which is very important in the NHS. You can't, school nurses won't have access to everything, but what they will do is have access to the mother's notes and to the other children's notes, and they'll look at everything and see, actually, I think, and they've also seen journeys that people have been on, life journeys. So again, they might ask me as a GP, Taz, can you do this, or Taz, can you do that? But also they pretty much can predict what I'm going to do or say in any given situation, because they're senior clinicians and they've known me for a long time, and local GPs and the local neurodevelopmental centre, our local one's called the Lighthouse Centre. So, and they give us an ask. Now, again, the resource is limited. So often what I do is say to the parent, actually, you're going to have to contact the school nurses. You're going to have to contact. And I can contact the health visitor and the school nurse. But the problem is with making that decision is, do you go home at 7 p.m. or do you go home at 8 p.m? You do have to give things back to patients. There's also something else in this transaction. Of course, when I say to you, Natasha, you do this or you do that, that's what I recommend, I suggest. And obviously it's not, I'll make it sound like an order. Of course it's not. It's all shared decision making, because we need to share problems and share our knowledge and make this together. But when we ask a parent to do that or an adult to do that, there's also this transaction of empowering you to help yourself. Have a look at this. Have a conversation with that. Have a look at the Live Well website at Southend. And actually what I'm doing is enabling you. And actually I might be giving you a power, a new resource that you can use for the next 30 years when you look after your family and you look after yourself.
Do you find though that some parents are like, but you're the GP, you should have the answers? Because you know, when you go in and they give you a list of places to start researching, and you're thinking, but I've come to you to kind of be my anchor, to sort of tell me what the problem is, not to send me back to have to now go and start hunting to figure it out? Or do you find that people actually appreciate being asked to be involved in that?
So I think you make a really valid point. And this is, again, about where GPs sit in society. And there is something around power and locus of control, which is the GP on a pedestal? Is the GP the person that should do the referrals to, say, the local neurodevelopmental centre or the local learning disability centre for a diagnosis of ADHD or neurodiversity or learning disability? Or should others be allowed to do it? And one of the contexts is we're now in an NHS where there are 2,500 GPs out of work, and we've developed a system where there's many different professionals in primary care. So I think we have to move to this model where the GP isn't on a pedestal anymore, and actually we work in partnership and we make shared decisions. Now the other side of it is and we go back to Maslow's hierarchy of needs. The thing that primary care is really good at is looking at the big picture. And if you're being beaten up because you haven't got enough food to put on the table, or you haven't got clothes or a washing machine or a bed for your family or your children and yourself, that's where the safety mechanisms lock in, where we think about inequalities, and we think about, in the NHS, there's this thing called Core 20+5, where we think about what puts you at more risk and makes it tougher for you to succeed. We think about ACEs, adverse childhood experiences that you as a parent may have had, or maybe things that the child's going through, which makes the odds of succeeding in terms of connecting with other people, mental health and self-esteem, feeling included, less. And that's when we take over. We say, actually, we'll do this. We'll do the referral therapy for you, or we'll do the contacts to trust links, or we'll arrange for this, that, and the other. So, and often from these consultations, we have 12 to 15 minute appointments, most of us. Often in these consultations, they massively overrun, because I'll have 3 or 4 or 5 referrals coming out of that consultation. And obviously, you can imagine my secretaries love me for that. But of course, I'm thinking to myself, this patient, and as a GP, I call them patients, I only work in clinic 1 day a week. So if we share each other's knowledge and experience and we try and do things together, that shared ownership makes us a lot more forgiving and accepting of each other and trying to do the right things. The other side of this is that I work in safeguarding inequalities, I work in learning disability, I work in neurodevelopment. Not every GP works in that sphere and has the confidence or knowledge that I have. And again, it's sometimes part of doing this podcast is so that you can lead the colleague you're going to see and say, can I ask about that? And then you can have a conversation about it. And 99% of colleagues, if they don't know about something, they'll say, I don't know about that, but I'll find out and I'll get it sorted for you. I'll send you on the right path.
Which is extremely helpful, because a lot of the time I think parents come in not knowing where to begin, especially I suppose if a school come to you and say, we've noticed some behaviours, maybe you should go and look into it a bit more. I suppose I'm not really sure how schools approach parents when they're concerned, and whether they give you a list of places to go or whether they refer you straight forward and go to your GP and find out. Do you know how it works a little bit? Or
So, I mean, what people can't see in this podcast is there's a wry smile on my face, and it's one of those where I think it's a love-hate relationship between teachers and general practices, because often they ask us to do things which we can't do, and often we ask them to do things which they can't do. And actually, these teachers, my local school is Belfairs, and the head of Belfairs currently is Bev Williams, and she's a wonderful woman. I wind her up as much as I make her smile. And she's great. And it's one of those things where an example is a child displaying signs, hyperactivity, impulsivity, a lack of attention. And the parent might be thinking about ADHD. And they'll go to the school. The teacher will say, go to the GP for a referral. And I think there's several mechanisms. What we're talking about here, from my perspective, is something called the early help system and the early help offer. And what we want to do is have a multidisciplinary approach to assessing the child and the family. So when a child displays ADHD symptoms, basically the teacher can do an early help referral, the school nurse can do an early help referral, the GP can do an early help referral. In fact, I dare say anyone can do an early help referral who's a professional working around the child and family.
May I stop you? What is an early help referral? What is the definition of that?
So, for instance, in the case that I've given, we're thinking actually this child needs help at an early stage in their life. And for me, and I'll go back to was talking about us being a lifelong service. The life is a line that person's going to lead, that young person's going to lead over hopefully 70 or 80 years plus. But if we can get early help early, maybe we can change things and actually help self-actualization sooner. So the early help offer is, what will happen is there'll be a multidisciplinary team that assesses the referral for early help, which is based at our local authority at Southend City Council. And then what they'll do is say, okay, this is needed, or that's needed. And it could be something like social inclusion, that feeling of belonging, as I go back to Maslow. It could be around parenting skills support. How do you cope? How do you speak in front of the children? What are the children actually seeing and what are the children actually learning? And can we change that to actually help improve those, I'll call them symptoms, but improve their quality of life and their behaviours or things that are occurring that are leading to adverse outcomes for them or their family. They'll be looking at things like nutrition and food. They'll be looking at everything.
Okay.
And then there's this thing around, okay, do we need more? Do we need to do a referral to, say, for instance, the local neurodevelopmental centre? Do we need a diagnosis to help that child and the family understand how that person's brain behaves and adapt and change what they do to help that person succeed at life and help improve relationships, outcomes, etc., etc. So the other thing around that as a GP often, and with my set of skills, is often I feel that's a hospital pass to the Lighthouse Centre when I do an early help referral or do a referral to the Lighthouse Centre, because I often feel sorry for this community paediatrician who's expected to have all the answers for something that's got maybe 5 or 7 contributory factors to it. And again, I'm going to go to a model of mental health and succeeding at life. But often, as practitioners, we look at predisposing factors. It might be genes, it might be diet, perpetuating factors. It might be disharmony in the home, and that could be sibling upon sibling. It could be parental. It could be other people from outside, and precipitating factors. Has something like transition from primary school to secondary school. The stress of that brought this on, and whether that's for the parents or for the children or for both. Again, what I'm trying to give your audience, Natasha, is an insight into the way we think, when often we only say 2 or 3 words to you when all these things are going through our heads, when we're talking to you in the consultation, or when we're talking in a multidisciplinary setting of trying to help a child, or when we're talking to teachers. And of course, I talked a little bit about locus control. I don't know whether I said it, but there's this thing called parity of esteem as well. Parity of esteem amongst professionals is still not there. It's still considered that general practice are the guys that open up referrals and the gatekeepers of services. I'm quite cross about the fact that teachers who can often spend 5 days a week, 8 hours a day, 30 weeks a year with our children, they don't have access to health and care records to look after these families. So we're very careful about data protection and our rights. Also, the primary caregiver for a long time in our children's lives is their primary school teacher. And actually, they see what's occurring, and we need to empower these colleagues with the caring, nurturing part of what they do. Interestingly, I had a conversation in a safeguarding partnership with a teacher who wasn't from our area, somewhere else in Essex, and they were quite adamant that none of their role is to teach parenting skills, but it is our role to look after each other and guide each other, and to use our voices to the best of our ability to help each other succeed at life. And also the trust that we have in our teachers when we pick them up, our kids up, when they're 4, 5, 6, 7 years old. The sheepishness we might feel if, for instance, they're going into reception and toilet training is not as advanced as you'd like it. They see that. They know that. They have experience of that. They know it. And one of the most important things for me is that to try and encourage my colleagues and all of us to not leave things unsaid. If you can help. Be positive and help.
We're in a time where people can easily take offense to something that isn't meant to be offensive, that is actually to help you. But because you've got your own issues and all your walls up, somebody coming in and saying, well, you know, we've noticed perhaps baby John isn't where he should be with potty training, you know, are you aware that he's about to enter school? Is there any way we can help? I think people get defensive, a bit like you're calling me a bad parent. But actually, no, they're not. They're trying to help. And that's the key word, isn't it? We're all trying to help each other be better people, be better parents, be better educators.
And that's the main reason why I'm here on a Monday morning, because we can do a lot of good here to have those conversations, to be less afraid of these people on a pedestal. And I want to reduce that gap. We're all growing all together. And like I said, I've been a local GP for a long time. I've been working for a long time. But it's very important we understand each other a little bit better and we're a little bit closer, especially in these tough times when money's never been so tight. Society and tensions and expectation and that sense of us being entitled to various things is at a different stage. How are you going to help someone in terms of actually having the biggest impact to improve their life or their child's life in a 10, 12-minute appointment? It's tough.
It is tough. I suppose it's tough on everybody, but in theory, by having extra practitioners in your surgery, you allow to kind of help people at different stages. So the people who need the nurse practitioner who's got the experience, who can help them meet that person. And if they need mental health support, they've got the counsellor and so on and so forth. So in theory, by dividing it up, it should make it a little bit better? Or do you feel people still just want to see the GP?
So, and again, it's about power, isn't it? And it's a conversation about power and that pedestal and parity of esteem. There's several aspects to this. General practice has never offered more appointments than it's offered now. So we're offering, even across Essex, we're offering millions of appointments over periods of time. So we've never, and it's great that and we've got this thing called get it right first time. So say for an infected toenail where you need antibiotics, really that should be an appointment that goes with the most relevant practitioner who, and that probably won't be a GP, probably won't be a nurse prescriber, it'll be someone else who can give your child, for instance, if they're not penicillin allergic, flucloxacillin, and give a leaflet on an infected toenail, possibly refer to a podiatrist or chiropodist. But also, we need to understand that with the advent of these, I've said 17 different professionals, they're actually quite new. They've only been around for 4 or 5 years. So there's also, we need that appreciation, that change in level of experience compared to, say, someone like me who qualified as a GP in 2005 and has 20 years under their belts, compared to someone who's, say, a new pharmacist prescriber who's been doing it for 1.5 years. So again, the key to it is asking, actually, do you know about this? Or can you direct me in the right direction? Or do you want me to fill in another e-consult or another submission to the practice to ask about this? Or could you send a task to someone and ask them about this? And again, one of the things I've stuck up on my wall is one problem per appointment. And I try and guide people that I want to be a safe practitioner and not make mistakes. One of the first things in trying to please you, trying to deal with those 4 or 5 things, Natasha, I'm much more likely to make mistakes because I'm rushing. And of course, the note keeping on that will be not very good either. So I won't be able to defend myself when I make that mistake either. So again, this is about empathy and looking at the world through each other's eyes. And yeah, I might have an FRC GP after my name. I might have this, I might have that, but it's experience, and actually those mistakes still happen, and probably more so as you get older. So there's that aspect as well. There's also this aspect of get it right first time. So people have probably seen that there's been a campaign locally in the Echo and online on the radio, and actually now we've got these 7 conditions which community pharmacists can treat. So we can take our children there and ask questions. There are very strict criteria, certain things like ear infections, you can't be above a certain age, you've got to be above a certain age, that you can get antibiotics off the pharmacist or be assessed by the pharmacist. But at the same time, again, that's there to help us access the best care we can as quickly as possible and as appropriately as possible. The other thing we've got is the minor eye conditions service, where we can type in minor eye conditions NHS, and you get given a website where you can type in your postcode and you can see your local optometrist, who again has prescribing rights, who's really highly qualified, who can treat things like basic eye conditions and also escalate things if it's more serious, and has that relationship with the hospital and the local ophthalmologist. So those are just 2 examples. Then there's things like with musculoskeletal conditions online, you can use the NHS app, and you can use the Get You Well, Get You Better app, and other things like that to help yourselves and empower yourselves to be better.
Going back to taking kids through school. When children go into school, we see the GP when we're poorly, but before that we have access to our school nurse. Yes? And then if we have more...
I'll correct you there.
Okay.
Next to that. So one of the things I don't want to do is dump responsibility to my really senior colleagues, the school nurses. So these are one of the options we have to look after our children. So you can contact your GP, you can contact the school nurse. It's one of those where I want you to be aware of them, but I also want you to be aware of how much they help.
We have our GPs, we have our school nurses, and we have our schools, and these are all meant to bridge together to create a healthy, happier child. When looking at that, if we mentioned earlier that there's early intervention plans that we can seek out help for parents if they feel the need to. Is the relationship between school, GP, and nurse as seamless as you make it sound?
Definitely not. Definitely not. Always rosy in the Garden of Eden, definitely not. So I think as a general process, as a parent, I would listen to the school. One of the things that I'd advise parents to do is to always look at their NHS app to see what I've written in the notes about any consultation with their child. And you can use the NHS app and use proxy access. And just the same, when you have conversations with professionals, don't be scared of writing an email back to that professional saying, we discussed this verbally, just to check, this is what I took away and this is what we agreed. And what it does is have a nice paper trail for us as parents about what's occurring in our child's journey and some sort of record, because often we don't have, as parents, records of what's occurring. So that's really important. I think it's the other thing to say is that the teachers, the school nurses, the health visitors, GPs, we only have so much capacity. So if someone says, go to your GP, the other thought I'd have is, this is not about teachers, it's not about third sector organisations, it's not about other colleagues, but you've also got to think, actually, if I do need a referral for my child to the local community paediatrician, do I want to force someone to write something that they're saying go to the GP for? And again, it's about that insight and empathy and that understanding. And again, is it a 6 p.m. conversation on so have a think about who would be best to write the message and who would be the best messenger. And certainly one of the things that I do is when an e-consult comes in, and at my surgery, that's our online triage, and we're 100% triage. For better or for worse, that's what we're doing. If a parent wrote an email, an e-consult to me and said, these are the things that are going on with my child, this is a little timeline. And again, I wouldn't want anything huge, so I can do a referral from that history. And one of the things we were taught at medical school is 70% of diagnosis is from the history, not from the examination, from the history. So you've given me all that. And I know that sometimes the questions on there are quite contrived and convoluted and feel like a blocker, but they're more questions than I would ask. And any of you that have been looked after by me would know that I probably don't ask that many questions. And you might say, oh, you're concise, you know a lot, but actually, I do love the detail that the computer gives me and the technology gives me. So with that information, I'll do the referral to the community paediatrician, and actually you won't end up seeing anyone at the practice. It's on that history that I'll do that referral. So that's probably the journey that would occur most commonly for us.
Your parent would contact you via however they contact you.
Possibly through the online triage form, and then I would do the referral.
Okay, and then the referral will go wherever it needs to go, and they'll be the next people to contact you.
Yes, and usually it'd be about a 4-week wait before it gets acknowledged, and that 4 weeks often you feel like you've been lost. There are waiting times for neurodiversity assessments in children and adults across the country. Some waits can be 4 or 5 years. Some waits can be 1 or 2 years.
Is that why a lot of parents are choosing to go privately for diagnosis? If your child starts school at 5, they may only be diagnosed at 10, and by then they've travelled through school with all these problems or issues without a reason for it.
So one of the great things, the reason we called it early help, and I say we because it's all of us that part in that. Health, the local authority, educators, we all are stakeholders in looking after our population, as well as the third sector and community and charity organisations, is because we need it to be broad. So is it as simple as there's something wrong with this child? And do we want to define somebody like them? No, never, ever, ever. We need to be holistic. We need to look at everything. We need to look at the precipitating, predisposing, perpetuating factors. We need to look at the biopsychosocial model. So we need to look at physical causes. We need to look at mental health causes and traumas. We need to look at actually what are the circumstances what's the child's eyes and what they see, what they're experiencing that's changing how they are and who they are. And we need to make evidence-based interventions and the wins where we can win. So that's the other side of it, is sometimes you can't influence everything. And when I say we, it's all of us. It's the parents, the child, the interventions from the NHS or the local authority or from school. So all of that matters. Early help. And actually, the other side of it is labels. Labels are good for trying to get more help for a child, say a statement of educational need or early help. But from the child's side, is it good to go and collect a diagnosis for themselves? And does that make them feel even more there's something inside me that when I'm just different, that there's something wrong with me? And again, what does that mean when that child becomes 20, 30, 40, 50, 60? How does it knock onto their relationships? How does it knock onto their aspirations for their life and their hopes for their life? And one of the big things we should know about is inequality of aspiration. We've got big swathes of children locally and nationally who feel that there's no opportunity or chance for them to be certain things that they want to be. So that's why early help is quite an important way to go, to look at everything rather than think, actually, am I setting up a hospital pass for the community paediatrician? Someone's very cross. They've waited 2 years, 3 years to see them. And now this community paediatrician in this 35, 40-minute appointment is expected to fix everything.
Managing expectations, but I suppose with the early intervention, they can put things in place that may help, and it may not be what you think it is. It may be something else in your child's life that is causing what's going on. So they're able to look at the whole picture rather than just what's happening in that moment.
I think that's absolutely fantastic, Natasha. There's something called Johari's window. Known knowns, unknown knowns, known unknowns, and unknown unknowns. And it's basically a model of managing uncertainty. And I must say that this has been a part of my family's journey as well. So I've been a patient, I've been a dad going through all these things I'm talking about. So I've lived through this as well. So there's a lot of emotion, a lot of conviction in what I said. And I know that a lot of things I might have said are wrong. But also, please don't think it's just from a doctor's point of view, because me and Natasha were talking before starting recording, and I've lived in Eastwood. My kids have grown up in Eastwood, and probably many of you know me and my children. So I'm my wife, who's a health visitor and manages health visiting and school nursing services. So she knows I live and breathe this. And we are boring people. We do just talk about work at home. And this thing around hearing the unexpected and that first feeling within ourselves, who are you to say that about that? Actually, I'm an expert, and I've walked this path a few times with a lot of people. And I've got this lovely quote: good judgment comes from experience. And experience, where does that come from? Poor judgment. So you have to show a bit of faith in people that are saying, actually, this is what I think. And you've got a choice. You can do that shared decision making, or you can say no. You've always got the choice of saying no. But again, it's worth thinking about, okay, what do I know and what do I not know? And actually, is it worth trying it, seeing what it's like?
As we come to a close of our episode, what would you say are your tips for parents?
Be accepting of help. And the biggest thing I'd say is be accepting of help. And I love this concept, this African concept of Ubuntu. I am because we are. So include your child, get them socialised earlier, get them into clubs. Any offers you get to have them doing stuff, do it as much as you can within the scope of your tolerance and your ability. And it can be really tough times at that age when you're a parent or a lone parent or there's difficulties going on. But take the help and try and be someone who is part of the community and included. And that gives you and your children best opportunities to see all the opportunities available for you.
Okay, wonderful. Thank you very much. Thank you for joining us. We look forward to having you on another episode. Hopefully we will discuss in further depth things like learning plans and things that GPs have access to and potentially safeguarding.
Of course. You're most welcome, Natasha.
Thank you.
Thank you for joining us on today's episode, and we truly appreciate you listening. Don't forget to turn on your notifications, subscribe and follow to stay updated on future episodes. We look forward to seeing you next week.